I think for me, coming into preparing for this panel, I realized one of the things that I was interested in around deemed consent was really heavily influenced by the pandemic. And so I think we're kind of at an interesting moment in time in Nova Scotia, if you will. We had our new legislation, the Human Organ and Tissue Donation Act, proclaimed in January of this year. And at the same time, we're experiencing a pandemic where there's been a lot of different conversations and calls to things like solidarity. And it made me wonder then, now that we have two things going on in our province at once, what about considerations of solidarity in relation to deemed consent, particularly within our own province? But I think, as you'll see, some of what I'm saying applies in Nova Scotia, applies in Canada, but may also apply certainly internationally and globally in that broader sense. But I'm really interested in thinking about it and talking about it from a Nova Scotian or Canadian perspective as one ethics lens that can be applied to these two healthcare system or healthcare examples. And so as we get into it, I hope you'll indulge me as I sort of give you a snapshot of what I've been thinking about and reflecting on in relation to solidarity, and really using the pandemic as a way to help compare and contrast different things that we can be thinking about in terms of deemed consent and the way that our legislation has framed it in Nova Scotia, to sort of highlight what are some of the strengths and potential areas of concern or question related to calls to solidarity as we think about organ and tissue donation and transplantation in particular. So as I get into talking about solidarity for the next few minutes with you, I certainly realize that solidarity is not a neutral term. When you hear that word, depending, I think, on where you're located, what the culture is that you're immersed in, sort of the history of where you're from, all of those different things may give you different senses of what solidarity actually means, or what it is a call to when people say we're standing in solidarity with each other. What images and thoughts does that evoke? So part of it is recognizing that, as I say, solidarity isn't a neutral term, also as a way of saying there's not one definition of solidarity, I think, out there that everybody agrees to, even while there may be common elements to it. So the focus that I'm taking in relation to solidarity to look at both of those examples, as I said, is one that's really more grounded in a bioethics focus. There's been arguments put forward in the bioethics literature sort of saying that the solidarity is gaining more prominence as a concept to apply to help draw attention to particular ethical considerations or ethical commitments that might be being made, where solidarity might be a useful way of analyzing and assessing what's going on, as well as in the healthcare literature. But I'm certainly very much interested, coming from an ethics lens, about those normative considerations. What does a call to solidarity actually mean, ethically speaking? And a couple of quotes just to sort of help situate it even a little bit further what I'm looking at. These two quotes come from a special issue in the Journal of Bioethics. In 2018, that was a special issue around solidarity. And I think the ways in which both authors here are talking about solidarity really helps get at some of the things that I'm interested in. So it's about what connects us when we're working together in different ways, when we're designing institutions and policies, right? So thinking about sort of our healthcare system and where deemed consent fits into that from an organ and tissue donation and transplantation perspective is of interest. But I also think that call to what's the honest debate about what we actually owe each other, right? And how does that work into different things about as we make visible, as the second quote says, our shared vulnerabilities and our human needs, right? Sort of what's that, again, call to solidarity really calling us to? And what are we meant to recognize and address when we're standing in solidarity, right? Or using a notion like solidarity to help draw attention to particular issues we're trying to address. And I find the work by Gaston Fernandez, who's another Canadian scholar, really quite interesting, as he's helped to really highlight three critical aspects of solidarity as I have them listed on this slide. So it is about relationship. Who are we in solidarity with? What defines that relationship? What's the aim of our solidarity, right? What are we hoping to achieve through solidarity or on the basis of solidaristic action, if you will, right? Where are those commitments coming from and what are we basing them on? And then fundamentally, right, and I think many of us make the association between solidarity and sort of a call for change or making acts that are towards changes or sacrifices in the name of something. So that question of what am I willing to do and give up in order to ensure the well-being of others, right? Is that notion that solidarity is getting at, it's not just about me, it's about us in a certain kind of way. And I really like the last phrase that's on this slide here about whether they are like me or not. And I think as we see, as we'll go through both with the pandemic and then moving into the OT-DT conversation and deemed consent, that question of whether they are like me or not becomes an important aspect and potential critique around some of the ways in which solidarity has historically been understood, about what's that call to solidarity, to that relationship, to those commitments based on. And so in that sense, then, I'm going to talk a little bit about solidarity and the pandemic. And I think certainly in Nova Scotia, in Canada, in probably every country around the world, there has been that sort of phrase that's been oft repeated, we're all in this together. We're all in this together. As our premier, then premier, Stephen McNeil said near the early part of the pandemic around lockdowns, he said, stay the blaze is home, right? Sort of a particularly Nova Scotian phrase, but kind of that follow the rules, stay home, do the lockdown. This is how we're going to get through this together. We're all in it together. We're all depending on each other to follow the public health guidelines and restrictions. And then I think we've seen that sense in Nova Scotia about how we're all in this together play out throughout the pandemic as well. So it's about keep it to 5 people, right? When you can bubble with 5 to help turn the tide. We care enough to get tested so others don't get sick. We have what it takes. We're getting closer, right? Sort of that call to like, we're all in this together. Keep going. We're going to make it. Then it's be part of our way forward as part of the vaccine campaign. And you notice the T-shirt on the lady in the picture around, I got the vaccine for you. Right, so again, that call about being in this together. This is about you. It's not just about me. It's about how do we work these things together. And so we start to see then sort of the call around solidarity in relation to the pandemic, at least at one level, is really a focus on what we all have in common. We have that threat of COVID-19 that we're all addressing. We have the experiences of the lockdown. We have a desire to be in the post-pandemic phase. And whether we all agree on what sort of the post-pandemic phase will look like or what we want most as part of it, I think there's still an ascription to, well, we all have a desire for not to be in the pandemic anymore, right? And so Beers would actually sort of frame this as maybe a call then to a universalistic solidarity, right? And I think you can see the notion of what type of solidarity is being called to there is that sense about what's universal. Regardless of who you are or where you are, there's a sense about we're all in this together. And very much that high level of that universal human condition. But I think it certainly, as many of us have seen during the pandemic, and I think have thought about and wondered about too, is, well, there is a whole other layer of this conversation that says, well, we're not all in this together in a different sense. That we're not all experiencing the pandemic and its effects in the same way. The pandemic has certainly brought into more sharp relief the impact and influence of structural injustices, systemic racism and oppression, and the effects that they have on whether people are getting COVID-19, how they're doing with COVID-19, but also just more broadly speaking about the social determinants of health and how much they do play into people's opportunities to be healthy or not, generally speaking, and how these aspects, these structural aspects kind of interface with each other to make it even harder to maybe to access healthcare in certain kinds of ways or feel part of healthcare or receiving healthcare in a way that makes you feel valued and part of things in that kind of way. I think we've also seen with the pandemic, as we saw what happened with many of our long-term care facilities, one in Nova Scotia in particular was hit very, very hard early on in the pandemic. There was that sense about, well, if we're all in this together, look what's happening to long-term care and in our long-term care sector, in our province, in our country, and beyond. That really sort of said, are we really sure? Prior to the pandemic, did we have the sense of solidarity that we thought we did in terms of what's happening and how we understand that value to be coming into force, whether it's during a pandemic or outside of a pandemic? And so the implications for solidarity then, I think many have seen and sort of talked about, which is then we have to be cautious about relying too strongly on the universal human condition as that basis for solidarity and related calls to action. That in some senses, if we kind of ascribe too much to that universal human condition, we're missing the important things that make us different from each other, whether those are structural and experiential, but that there's that sense about, well, how much do we rely on the we-ness, as somebody has said around solidarity, and lose sight of and really value the importance of talking about who is included and who is not when we're making claims of solidarity or the we that's in this together, right? And I also saw sort of later on in the pandemic, there was a party that happened sort of in contravention of our pandemic restrictions in the province. And there was sort of a call and conversation about what does it mean to be a good Nova Scotian? And good really, I think, in a moral claim or an ethical claim about, well, you want to be a good Nova Scotian and good Nova Scotians follow the rules. And I think in that sense then too, it's sort of that interesting call about, or call to pay attention to the ways in which solidarity can also then become something that becomes about them. They're the ones that are the problems. They're the ones that are the concern. We're standing in solidarity, you're not, right? And I think those are ethically important conversations and distinctions to be paying attention to. And this is where sort of the suggestion then is, well, maybe if it's not so much that universal call about the human condition or that universalistic solidarity that's important, but more around social or political solidarity is maybe those theoretical aspects or those conceptions of solidarity that we want to draw more strongly on, which is thinking more carefully around about who is the group that's acting to advance interests, about the political side around focusing on issues of inequality and inequity and different groups coming together to help support a change to some of those structural features, addressing racism, all of those kinds of things that you might put in there. Would it be more helpful then to kind of more appropriately nuance and talk about that messaging in relation to solidarity, not just so much we're all in this together, but here's how we can be together to make changes that we recognize are important in our community and in our society. And with that being said, that's where I'm going to sort of shift into then, looking at solidarity in the context of our healthcare system outside of a pandemic and into organ and tissue donation and deemed consent. So if we sort of take the pandemic as sort of a crisis moment or a rallying time where people come together and really think that crystallization of sort of our action and our focus, we can then step back and think a little bit more about, well, where does solidarity show up as we talk about healthcare in Nova Scotia or in Canada? And I think in many ways, for me, it seems like the sense of solidarity is kind of steeped into how we think about our publicly funded healthcare system, right? That part of the basis about why we have the Canada Health Act, why we created a publicly funded health system, was an acknowledgement of the need and suffering that's there for any person in our country, and that need to and desire to attend to the needs of those who are the least well off. And we didn't want folks not to have that kind of safety net, whether it's other social systems or healthcare or both. We wanted to provide that safety net for folks so there is access to healthcare when it's needed. And I think what's interesting then too is, as I've alluded to with the Canada Health Act, there's sort of a sense of civic solidarity that might be drawn upon here to frame some of what's happened then. Well, we thought it was important enough that we created legislation, that we pay taxes into this, that we have a system that says, if you're going to act on and be in solidarity with each other and say these things are important, here's one expression of that. Pay your taxes, and it feeds into those things that are really important for others, recognizing that we're part of, right? It's not just about me, hopefully, from that sense of solidarity. It is about all of us. But I am paying taxes. It's sort of more of a indirect way in which you can demonstrate that you care about others around you and want to see their suffering addressed. And so if that's one way of thinking about solidarity in connection to our healthcare system, it's not surprising then to think about solidarity as part of organ and tissue donation and transplantation, right? That solidarity has been identified as a value that should guide this system in Canada, right? And sort of being talked about. And I think when there's been in conversations with others around organ and tissue donation and transplantation, there is that sort of sense in which solidarity seems like a natural fit. If you have a list of all the different values that we might be talking about, solidarity makes sense. It appeals to people. There's a sense in which it captures something that's important. And whether that's sort of an extension of how we think about solidarity in the context of healthcare, and this is a specific instance of it, or whether it captures something important in and of itself, I think is something that can be explored a bit further. Recognizing that one of the things that's really important about organ and tissues in particular and how we address this need of others in our community or in our society is it's through donation. Whether it's an opt-in system, whether it's a deemed consent system, it fundamentally relies at some level on people being willing to donate tissues and organs. We can't necessarily address that need in any other kind of way. So the sense of solidarity there might be particular in some kinds of senses. And yet, I'm still left, as I'm working my way through this, I'm still left wondering, well, what role is this value actually playing? Beyond sort of a, yes, it's about solidarity, yes, it's important, we want to have OTDT and have a really robust system for it in Canada. But beyond that, what work is this value actually doing? Is it actually doing something? And I think that's important to look at in the context of deemed consent. So part of it is about that high proportion of Nova Scotian support deemed consent. Maybe that's support OTDT. Is that a way to say, yes, if we support it, then maybe that's sort of one move into making the deemed consent model with our new legislation, then says at least to some extent it's solidarity based. Is that an appropriate argument to make? Is that something that we can argue for? Possibly, right? And sort of work that way through. And maybe that sort of, as we look to other countries, that's part of the argument that's being made. But it's also an interesting way then to think about the comparison and contrast with the pandemic, right? So the pandemic might be a singular event. It might be time limited in some senses, even though it's kind of ongoing at the moment. But it's relevantly different around organs and tissues where it will be an ongoing need for organs and tissues. So how do you maintain that motivating sense of solidarity in the face of a need that's continued? Is moving it into legislation, moving to deemed consent, the appropriate way to continue to ensure that that happens from a civic solidarity basis? Is that the way we want to go? We also recognize, as I've alluded to a little bit earlier, sort of a difference between we all might need healthcare at some point. Not all of us will need organs and tissues. So does that variability play into how people think about their motivation or connection to, or the way in which they're in relationship with others from that solidarity focus? I think many of us, or even all of us that are listening today and part of this conference, will recognize that when we talk about organs and tissues, there's often a sense in which we're requiring or asking for something that's extra or different. And that then it becomes very fundamentally intertwined with other beliefs and values about how you understand your own body and what that commitment might be from that solidarity perspective. If that's the angle we're taking, becomes really interesting to look at. And also then, and moving into sort of my closing, is if solidarity is part of moving to deemed consent, and if this is a value that we think is important to unpack further, we also then need to consider the follow-through in relation to this value. That attentiveness to that critique of the us, the we, and the others, who's part of it, I think sheds light on and raises questions in a different way about some of the conversations in OTDT around deservingness of organs, about who maybe has contributed to needing an organ versus others, right? And sort of that might add something to that conversation. Drawing from the political solidarity perspective, we might then really say, well, if solidarity is part of the motivation for moving to deemed consent, then we really have an obligation to address inequities that might be part of our OTDT system and really look at those policies all the way through from the donation itself to the transplant recipient and what happens. And then to fundamentally think a little bit further about how does solidarity and trust in the system connect together as well. And so that, as I said, is my sort of snapshot around solidarity and organ donation and tissue donation, specifically moving towards deemed consent. And just I want to say thank you for listening, and a recognition that I'm a part of the LEADER project, which is evaluating this shift, as this slide connotes, and just really want to acknowledge all the partners that are part of this project too. So that's where I'll end at that and hand it back to you.
Fantastic. Thank you, Christy. A lot of good things to think about, especially in terms of how that sense of solidarity is incorporated into a culture. I'm sure we're going to get into that in the discussions. So next up is another LEADER collaborator, Robin Urquhart, who is has a few roles. one of which is as the endowed chair from the, oh boy, I just lost my, went to full screen there. The endowed chair from the Canadian Cancer Society, Nova Scotia Division, chair in population cancer research, as well as being an associate professor in the Department of Community Health and Epidemiology at Dalhousie. So Robin, it is now your turn, and looking forward to your talk.
Thank you. Oh, yeah. Sorry, I thought I was on mute. Thank you, Matt. I decided to put it up ahead of time to get it up beforehand. And so thank you very much. I'm really delighted to be here speaking to you about some work we've been doing in Nova Scotia around understanding the views of sort of underrepresented and equity-seeking communities, specifically around organ donation and tissue donation, but around this deemed consent legislation that we now have. I just wanted to say I have no disclosures to declare, and this work is, the work I'm presenting was undertaken as a part of the LEADER program, so this bigger research program that's been funded by Health Canada to sort of look at the implications and the impacts of this legislation. So the context, obviously, is that deemed consent for organ and tissue donation came into effect in Nova Scotia in January of this year. And so we've undertaken work, research over the past 8 to 9 months. We've been doing interviews and focus groups with leaders of underrepresented and equity-seeking communities to really inform the implementation and to inform the rollout, and also to get lessons learned that may be valuable for other jurisdictions. And these include leaders from leaders of faith-based communities, leaders of the African Nova Scotian community, our LGBTQ2+ community, newcomers to Canada, and so on. So I'm going to present this research at a bit of a high level, and there will be a bit of text in here because there are some long quotes, but I thought they were really important to put in fully, because I think it's important for these participants to be telling their story and not just for me to be doing so. So I'm going to talk about 3 things, or 4, sorry, key things: alignment, trust and relationships, cultural competence, and education and communication. So in terms of alignment, interestingly, all the participants we talked to, so all the leaders of these communities that we interviewed or were involved in our focus groups, were supportive of organ and tissue donation because it aligned with their personal values. So many, certainly most, were already organ donors that opted into the system. The other thing that was really important was that organ donation is aligned with religious, I'm sort of reading off here, so I want to fix this here, with religious beliefs, which was really critical for participants from our faith communities. So and that's from our Christian communities, our Jewish communities, and our Islamic communities. And so I do have a quote right here. And this was a quote from an imam. "Saving lives is a very noble cause, very noble. Even Quran, encourages people to save lives." He said, "If you save the life of one person, it's as if you give life to the whole humanity. It is in the Quran, mentioned clearly. So it is something we need to encourage people to participate in." At the same time, particularly for participants and leaders from Jewish and Islamic communities, deemed consent for tissue donation is a much more complex issue. And this is really for 2 main reasons. One is that common to both faiths, there are a number of rituals and practices and traditions that happen after death. And so the concerns are, how will some of these rituals happen if certain tissues are removed, for example, bone and skin. And then the other issue that makes this much more complex is that, as you just saw, saving lives is imperative. It's very important. But unlike organ donation, where you're sort of saving lives in terms of most organs for sure, tissue donation improves people's quality of life. And so for many people, there is a distinction here. Again, going back to the complexities around rituals after death and so on. So this is a quote from a rabbi. "In our tradition, the most important thing is saving a life. Now, where you run into a lot of debate within the Jewish community, among Jewish scholars, for example, is at what point is enhancing life also in a similar way. Blindness. And there's consensus that if you're going to restore somebody's sight, that's almost to the point of saving their life. But then it becomes more complicated. And this sort of complication and this complexity was certainly emphasized from leaders of the Islamic faith. I'm going to turn to trust and relationships. And so although people and our participants were highly supportive of organ donation, organ and tissue donation, there were many issues related to trust and damage to relationships that need to be acknowledged and addressed within the context of deemed consent. So I'm going to give 3 examples. One is certainly the systemic racism within healthcare that many racialized communities have experienced and continue to experience. And this has led for many to a high mistrust of the system and really a lack of confidence in the system. So here's a quote. "I've always felt that why should I go to my death with something that's useful for somebody else? It doesn't make sense." So this person's very supportive of organ donation. "Now, at the same time, I'm an African Nova Scotian. I've always been mourned by other people, and I'm conscious of myself because of the racism and discrimination that exist. So I, at the same time, have recognized in me the reservations around they'll kill me so they can get my organs. And that is certainly a general sentiment. And my philosophy has been, what the heck? They're going to discriminate anyway, so I still may help somebody along the way." The next example that I'll give is really the damage to relationship that, in particular, men who have sex with men have with the blood donation system. And because of this damaged relationship, and because of what they really perceive as discrimination, participants expressed a lot of confusion around why the system would want their organs and tissues, but would not want their blood. And they also really described a damaged relationship with sort of the donation system at large, and that they have experienced harms from that. So, participants, the folks we talked to really were very supportive of organ donation and really are excited to be able to donate. But they're also fearful that that they will be rejected. I suppose the best way to put it is they'll be rejected in death as they feel they've been rejected in life. So here's a quote from one of our participants around this. "I do genuinely worry that they're going through the thing." So this person means sort of after death, going through eligibility criteria. "And they're like, oh, that dude was gay. Maybe we're not going to take his organs after all. Because if they're not going to take my blood, my organs are bathed in my blood. Like, am I going to be rejected? I mean, obviously it's for gay men, but also transgender women or like bisexual people. I want to donate, and it's very disheartening that I cannot donate blood because I would. Like, I'll give my organs when I can. So there's this sort of, like, it's this weird dichotomy. I'm very excited that I can donate my organs, but I'm also frustrated that my organs are okay, but my blood is not. And this creates a real tension. And the third thing around trust, the third example that I'll give here, a little different, but still for leaders in particular of the Jewish and Islamic communities, issues around trust around the organ donation and tissue donation were also very prevalent. And really from their perspective, there is a need to trust that healthcare providers, physicians will do absolutely everything possible to save a life. But if that life can't be saved, they will then do everything possible to respect the person after death. Here's a quote. The value that the imams expressed of wanting to, we would say in Judaism, be very strict about saving lives. We want to take all the resources, save as many people as possible. But the other side of it is something that we in the religious traditions express, which is to be respectful of the dead. And that's something that we really can't expect doctors to do for us. We have our own ideas of what is respectful of death. So I think that what we all need to sign off on is the understanding that we are entrusting these physicians to treat our dead with the respect that we consider to be essential. So in terms of cultural competence, So all participants, they may have used different language or sort of said it in various ways, but they really all emphasize that cultural competence and safety is essential to the rollout of this legislation. And, there were quite a few people that expressed disappointment and sometimes frustration that their communities were not engaged from the very beginning. And when I say that, I mean from the, before they even started drafting the legislation, so that the legislation would be culturally competent, and many people talked about equity provisions that needed to be in there for certain communities and different processes that could happen in different communities. And I think that there are many issues that were highlighted, and I don't have the time to go into them, that really, really show us the need for cultural competence at all levels. So certainly some of the things I've talked about, systemic racism, harms that have been experienced by men who have sex with men, again, by the donation system at large, the complexities we see around tissue donation. Like, this was a really sort of rich conversation that I've had with leaders of both Jewish and Islamic communities. And there are so many complexities around tissue donation in particular. The fear of doctors, physicians, teams not doing everything possible to save a life in certain communities. And so you had seen a quote from a leader of an African Nova Scotian community. And that was often a sentiment, but it also was a sentiment that was expressed by leaders in immigrant communities. And again, there are a number of things around that were discussed in terms of the LGBTQ2+ community around the definition of family, for example. And it can be very different for many people in that community. And so what does this mean in the context of legislation? How will this be addressed in legislation? How is it addressed? How will it be addressed by clinicians at the bedside? And then, just as one other example, in terms of sort of bodily autonomy in trans persons. And I think that issue, like that need for bodily autonomy, really underscores the need for a culturally competent approach, again, throughout the entire sort of all levels, in order to sort of empower people to make decisions around organ donation and tissue donation. The other thing that I'll say is that, or maybe I should go back before you read that, is that people were very much about, and Christy really in some ways we're sort of getting at this, that there's a real need for governments and those people in the health system, right, to recognize the concerns of the community, to recognize the harms that have been done and that continue to be done, and really to respond to the community's needs to make sure that we minimize any further harm. So this was a quote from one person. "You can't come into these marginalized communities that have very real issues, current issues with government and its many systems. You can't come into those communities with your cherry-picked issue without understanding that you're going to have to open up the whole spectrum of issues and to discuss the issue of organ donation within the context of Pride Health. The disproportionate amount of addiction in the queer community, trans health issues, medical support for trans folk, PrEP and PEP, and whether or not these things are being promoted and funded. All of these things are on the Pride Health agenda. And if you want to come to talk about organ donation, then you need to do so within the context of those conversations." So finally, certainly a high desire for increased communication and education, and certainly a general sentiment also that there has not been enough communication and information and education in the province around the new legislation. Many people talked about an obligation, like this is a serious act, right? And it does impact our bodies potentially and so on. So there is an obligation to communicate about the new law and its implementation. And certainly, that communication needs to be done in a way or in ways that people require. So for example, it has to be easy to navigate, easily accessible in terms of language, in terms of compatibility with assistive devices and so on. It was also noted that the communication has to be culturally competent as well. So this person said, "I'm sure those communications people have tons of experience and all that and do a great job, but are we doing enough to ensure that the information is conveyed in a way that resonates with particular communities and what their perspective on things will be, and from folks who understand the history of those particular populations and so forth? It may fall on deaf ears, as they say, you know, if it's coming from a person who has no understanding of the lived realities of particular communities, and it's going to land on them totally wrong, right? So the bottom line, my last slide, is that people like we've seen in polls of Nova Scotians and Canadians, like people are highly supportive of organ and tissue donation. And there's a genuine desire from these communities to move forward with this, but to do so in culturally competent and safe ways. And I think everything that I just talked about, just very briefly, but talked about, all again exemplify the need for cultural competence at all levels. And by that, I mean at the level of the legislation itself and the institutional policies that we put in place to sort of implement the legislation, and, you know, at the bedside, clinical cultural competence in terms of having these conversations with people on the ground. So I will stop there. Again, just to acknowledge, obviously, all the study participants and research staff, and certainly Dr. Steve Bede, who was my my sort of co-investigator, co-lead on this work. Thank you.
Fantastic. Thanks, Robin. And I really like the way those two talks mesh together with Christy giving an idea of solidarity, and your talk showing how there can be fractures between the dominant culture and the underrepresented groups within a jurisdiction that are a threat to that sense of solidarity. And I think that's a very interesting topic. So our next speaker is going to be Stan Kandelman, who is currently an anesthesiologist working at the Royal Vic in Montreal. But unlike so many of us on this call, has actually worked actively in a presumed consent model when he was working as an intensivist and anesthesiologist in France. So with that being said, Stan, I will turn it over to you.
Thank you very much, Matthew, for the presentation. And thank you to all the organizers for the invitation. It's a great pleasure to be here. Are you seeing my screen now or not yet?
Not yet, Stan.
Okay. Sorry about that.
And while you're pulling it up as well, don't forget that questions can be placed in the Q&A, and we'll get to those after Stan's presentation. And we see your desktop now, but not the full screen of the presentation.
Shouldn't be long.
There you go.
Perfect.
You have it? All right. So yes, thank you very much for the presentation. I'll try to be as interesting as Christy and Robin before me. This is a bit different type of presentation because it's an actual modification that has been taking place in a country that is different, because it was in France. So I'll try to be interesting. The reason also I'm here is I worked in France is in this opt-out system as an intensivist, and I was also lucky enough to be the site director of my institution for organ procurement and the director of the network of the northern Paris area. And in this job, I had the chance to work out on a research project, which is the Canvas study, which was a study made to try to understand what would be the impact of guidelines to how to meet with the relatives of a deceased patient and to address the organ donation issue. And as a matter of fact, so first of all, I received a grant for this study from the Agence de la Biomédecine, which is the French agency on organ donation. So I declare it as a conflict of interest, although it has nothing to do with the law change. But this project started in 2014. And we started gathering that data from then to 2018, and the change of the law happened in 2017, which makes the study super complicated. But at least I can show you some data and stats being done on data, which is not done by the French Agency on Organ Donation. So I'll present you this data. So the plan of my presentation is, first of all, what was the modification of the law, what that happened in 2017. And for that, I will present you briefly what was the previous legislation, what was the history of modification, and what is the new legislation. And then I will enter in the impact on donation of this new law in terms of global refusal and what would be the impact on healthcare providers and on population. Unfortunately, you'll see that I don't have much data on that aspect. So just to give you a context of how it is in France, and it's just to make a comparison. The way to compare systems is to compare the donor rate in terms of donor per million of inhabitants, and you see that France is doing pretty well, around 30 donor per million of inhabitants, which is again a good rate. Another context that I want to sorry. Yeah. Another thing that I want to show you is this. So this is a slide showing the types of donor per year. The blue being the donor being diagnosed when the death is diagnosed by neurological criteria, so DBD. The green are living donors, and the purple and blue here are DCDs, either uncontrolled in blue or controlled in purple. And just to show you that the controlled DCD program began in 2016 only, unlike many different other Western countries. So I will be not, for the rest of this talk, I will not be talking about DCDs, but only about DBDs. And one last thing I want to tell you, I should have said that in the introduction. I'm a doctor. I'm not a jurist or a lawyer. So, and I'm going to talk about the law. And of course, and there are some jurist specialists in the audience. So I just want to be taking it to your attention that every word, of course, is important in law. But these laws are not translated in English. So I always put, when I talk about the law, I always quote the law in French and I put my personal translation, but it's only a personal translation, okay? So the first organ donation legislation in France was written in 1976, and it was actually an actual opt-out system. Also called presumed consent. I put some quotes for presumed consent because nowhere in the law this expression is being used. And I find it interesting because even in France and with official authorities, whether it is the French Ministry of Health or l'Agence de la Biomédecine, we're all talking about presumed consent, but it's actually not the way it's written in the law. It's written in a like very periphrasal way, but it's not presumed consent. This being said, at the time of the debate in the 1970s, when you look in the written debates that happened in the parliament, this law was based on two concepts of the national solidarity and reciprocity. Everyone can get an organ, so everybody should be giving an organ. The reciprocity concept and the solidarity. The talk of Christy was so impressive about solidarity. I'm not getting back on that, but this was the two concepts underlying the law. In this first version of the law, there was no specific mention of relatives or family. So that was in 76. Then the law was completely rewritten in 1994 in what is called now the first law on bioethics, sorry. And this law reinforced the three principles on organ donation stated in the 1976 law, which was no quantitative reward, stated in French as non monnayable, no money involved, anonymous donation, and again, presumed consent. But for the first time, there was in this law a description of the refusal modalities, which were a dual. Number one, obligation for medical team to specifically search with families for a potential organ donation refusal from the patients. And number two, the creation of a refusal registry, which only became efficient in 1998 because when a law is published in France, it has to be validated by an application decree, which took 4 years to be published. So until 2016, two refusal modalities, either being registered in the refusal registry, and just to give you an insight, back in 2016, it was around 100,000 people registered on this registry over a population of around 65 million people in France. And the second way to refuse was obtaining a refusal or a consent, but we're talking about refusal modalities by meeting with relatives. And there we could get two forms of refusal. Either the relatives would transmit us a patient refusal that was given orally to them, or the family itself could say, we are opposed to organ donation. And although it was going against the concept of opt-out, this was completely accepted, of course, by the healthcare providers, but also by the law itself. Then happened the legislation modification proposal in 2015, so before the change, of course. And I call it a hard change, and you'll see why. This is my expression. I don't know if it's correct, but it was the law proposition was written by a French deputy, Jean-Louis Touraine, who happens to be a physician himself. He's a transplant expert in immunology. He's also an expert in bioethics, and he proposed to establish the refusal registry as the single and only way to refuse organ donation. And he was very transparent about the three objectives he was aiming at, which were ensure that, number one, ensure that patient decision would be guaranteed. Sorry for the spelling mistake here. Number two, discharge families to get involved in the issue and the discussion and the issue of organ donation. And he was really insisting on the fact that addressing this issue with families at this difficult time is an extra weight on their shoulders. And number three, again, very transparent, increased donation. Of course, and I was so impressed with Robin talk about how cultural minorities wanted to be involved in the discussion before the writing of the law, and which is totally understandable. But in this case, it's even, I wouldn't say worse, but I mean, not only the cultural minorities were not involved, but no one was involved, to be straightforward. The healthcare professionals were not involved, population was not aware. And I'm not a specialist about how it works to propose a law in France. So maybe it's the way to do, they propose it and then they discuss, I don't know. But that's the way it appeared to population and professional that it was made this way. So those kind of articles went in the public media, like organs soon taken without family being consulted. This was in 2015. This was a soft article, but there were some very strong article, and among healthcare professionals, and especially organ procurement professionals, there was a lot of discussion, and people were pretty shocked. So discussion then started with national ethics committees, professional societies, intensivists, organ procurement organizations, the French Agency on Organ Donation, and also I forgot to mention, but religious representatives of different religions were also consulted. And the writing of the law shifted from a hard change to a soft change. So this is the law in French, and I translated in English. So the new legislation says that the inscription on the refusal registry remains the main way to refuse organ donation after death. The refusal registry becomes online, but the paper version remains. Number two modality, refusal may be notified to a relative on a signed document. And number three, a relative of a deceased patient may notify the refusal of organ donation that the patient would have expressed orally. In such cases, a document stating this refusal by the patient has to be signed by the relative. In the application decree, in that case, came very soon after the law being published. It was stated that organ procurement is a possibility given by the law. Every decision to proceed or not to proceed to an organ procurement has to analyze the context of the situation quantitatively and qualitatively, whatever it means. This sentence always remained very difficult to understand to me and to a lot of people, but this part of the sentence, organ procurement is a possibility, opens a wide array of still be able to accept that a family refuses for itself and not for the patient. So to summarize, until 2016, refusal registry and meeting with relatives with patient refusal or family refusal. And from 2017, refusal registry remains, meeting with relatives remains, but we can have a patient refusal by a written document given by the relatives or a signed attestation by the families that the patient would have refused. So just to be completely complete, sorry, there is this kind of like, I call it diplomatic. Some people say hypocrite. I try to remain more diplomatic. So, but in the Crystal National Database for Organ Donation that we fill in for every potential organ donor, we cannot fill anymore refusal from relatives because it's not part of the law anymore. It's not accepted by the law. So it has changed to this phrasing, context as not allowed to pursue an organ procurement procedure. So I just added this in the refusal modalities, families, and it happened, of course, in practice that because we slightly modified the way we did interviews with families, and we always insist on the fact that they could not refuse by themselves, but that we were trying to, through the meeting with them, try to know what would their beloved would have said. But some people say, we don't know, but we don't want. So this is not in the law, but it's accepted by the law, but under a euphemism, kind of say. I don't know if I'm clear. You'll ask questions if it's not clear. So other changes, possibility to consent to partial organ donation. So refusal for certain organs becomes possible, and published in the decree guidelines for meeting with families in the application decree. Yeah. So guidelines, very, very practical guidelines, where to do the meeting with families, how to approach the diagnosis of brain death, how to approach organ donation. This was published in the decree. So this is for the modification. Now I will enter the impact on donation itself. First of all, addressing the main topic, which is global refusal and more particularly family refusal. So if we look at the data from the Agence de la Biomédecine, and I'm just going to present it this way over time. So the green is actual organ donation. The blue is global refusal, global meaning family refusal or patient refusal. Blue is contraindication because of, well, medical history contraindicating. The blue and the gray are like contraindication because of medical history, and yellow are others. And the application of the law is here in 2017. So if we look at roughly, we don't see major change. It's not a game changer, definitely. We can see a slight increase of organ donation after the application of the law, at least for the 3 first years. And 2020 is difficult to analyze because of COVID, but no stats were done on this, so it's difficult to say if this was significant or not. So that's where I was happy to be able to use the data of my study, which is not published yet. So it's like a preview of what's going to be published, submitted, and then published. So, and this is not the main objective of my study, but at least I could compile this data for this presentation. Of course, after having asked the Agence de la Biomédecine if they could give me some other data, but they don't have other data to give me. So if we look, compared 2 periods, and this was the period that was chosen for the study, so it's just anterior to the change of the law, 2012, 2014, and 2016, 2017. Sorry, this is a mistake. It's 2017, 2018. So it's after the law has been changed. We can see that, first of all, organ donation, we can confirm this increase, and it is significant. There is a slight increase in organ donation. And there seems to be, well, there is a significant decrease in family refusal before and after the change of the law. But surprisingly, there is also an increase in patient refusal in a smaller proportion, but still there is an increase. Interesting to note that when we compile, so in the period after the change of the law, there was the information about whether a written document was given by the patient to confirm, to attest that they were against organ donation. And such a document was only retrieved in less than 9% of the cases. So in the vast majority of the patient refusal, it's the family that transmit us that the patient refused with no written document to attest it. And also to note, this refusal from the patient does not include the refusal registry, which is another category in gray here, but we don't see it because it's so small. It represents nothing almost. So significant increase of organ donation, significant increase of patient refusal, significant decrease in family refusal over those two periods. And I just wanted to zoom about the first slide I showed you about the opposal. So again, this is global refusal, sorry. So family and a patient themselves. And I added in red the family refusal because I also add this data. And it's just to show you that, yes, there is a drop in the family refusal rate from 21% before the law changed to 11% of total population of potential organ donors. But I just wanted to show you that there is a trend to increase. So there is also the question of lasting changes, and we'll address this in the following slides. And I'm almost done. So just a matter of timekeeping, moderation, don't be too worried. So I just wanted to show you this data on refusal registry new inscriptions. And this slide, I found it funny because there's a clear relationship. This is the 2016 data on refusal registry new inscriptions. And this is July of this 2016 year. And this is when the law was published. And of course, in the media. And there you can see a raise like almost eightfold on the new inscriptions. And these are the weeks before the actual application of the law on the 1st of January 2017. So a real impact quantitatively on the refusal registry inscriptions. And another way to show this is over the years, especially into 2017, a dramatic increase of new inscriptions. But as I told you, it remains very, very low. 2 weeks ago, the number of inscriptions, total inscriptions since it was created in 1998, I'm talking about the refusal registry, less than 500,000 over a population over 13-year-old, because you have to be 13-year-old to get in this refusal registry. You have to be over 13-year-old. So it's to be compared with a population of 55 million. So very low. What would be the impact of this new law on families? Unfortunately, no data, no study being conducted, no official study, at least to my knowledge, after having asked all the authorities. So I cannot show you, unfortunately, anything so far. What are the healthcare providers' feedback? I can give you, this is a mix of my feedback, but also I gave some phone calls and emails to my previous colleagues, and some of them talk about an apparent paradox, because of course there is a still too high proportion of family members who don't know the presumed consent law. There is so much misinformation about, people think this 2017 was the actual law that made the presumed consent law the rule. Some don't know this presumed consent rule, but in those family members who know the rule, the new law, there seems to be a better understanding of the law And sometimes some of organ procurement would say, yeah, it made people know what to say to end the discussion about organ donation. This is quoted, but I'm just reporting what I've been told by colleagues. Still remain a high proportion of families who haven't specifically addressed the issue of organ donation. And there was a big fear among healthcare providers and organ procurement organizations and workers that having families to sign a document would make discussions even more complicated and would make, at least if, as if it was less trust between families and healthcare providers. And this is not what happened. This is not what people told me. They more have the feeling that it's reassuring to families. But again, I don't really like to talk for families without asking themselves, and I don't have this data. Impact on the healthcare provider themselves. So in the Canvas study that we are still conducting, we actually studied the differences of conducting a meeting with relatives before and after the law was implemented. And unfortunately, I cannot show you this data because this data has to be published, and I didn't want to show it here, but there is no change. We don't see change in our population of healthcare providers. We didn't see change of the way it was done. Discrepancy, I told you about that. Was there an erosion of public trust after the change of this law? I cannot tell you anything about that because a poll was done in the population before the law was changed, and 84% of the population said it was in favor of organ donation, but we don't have a more recent poll so far. So in conclusion, to analyze the impact of this new law, this seems to be a small but significant increase in organ donation. A significant decrease in family refusal, but an increase in patients' refusal. Whether it's a real increase in patient refusal or a different way to gather information, I cannot tell you. There was an increase in refusal registry new inscriptions, but very small compared to the French population. And whether these effects will be sustainable in time, I don't know. And this is not really the conclusion, but as a previous healthcare provider in France, we all call for the need of real public information. I'll let you, I would like to thank you again. And this is the picture of a dedicated location that we installed in our institution in France, in Paris, in the memory of donors, which is also part of the law on organ donation, having a dedicated place to honor the memory of donors in every institution that does either organ procurements or transplantations. Thank you very much.
All right, thank you, Stan. So we're gonna start opening it up for questions and using the questions from the Q&A. So I'll invite all our presenters to come back. Before we get started, 3 quick little points. One, just as a disclosure, I guess I should have mentioned before, is that I am the national lead, with Steve Bede being the Nova Scotia lead of the LEADER program that was mentioned a couple times by Christy and Robin. So certainly involved a lot in that work. And frankly, Stan, we need to get some French collaborators to apply some of our methodology to these questions. I think that would be a great way to go. Also, for the record, just to make sure that it's said right up front, we will not be entertaining any questions around which community has the largest sense of we-ness, just so there aren't any giggles from the community. Also, and I do have a question for Christy, but I think we can go ahead and start though with a question. It looks like from, Phil Walton, asked about the solidarity that seemed to impact around the pandemic, and you mentioned this as well in your talk, and how that had impacted the implementation of deemed consent throughout England. And I wonder, Christy, if you have any comments on that comment from Phil.
Sure. Yeah. No, and I appreciate Phil mentioning sort of the NHS, because in some of my readings there was really an interesting conversation around how people. Sort of the NHS was a valued institution, and, kind of even if tattered, people were still rallying around, and that it was sort of a a really interesting knock-on effect of sort of that harkening back to why do we value something like the NHS, and that in the pandemic there was a sense of, well, what can I do to make a difference? How can I help? And in that sense, does that lead to then that sense of increased donation or not? Nova Scotia saw an increase in donation at a certain point too, right? So there's sort of a sense in which I think the interconnection between the pandemic and sort of the things it gets us to think about how do we help each other and what do we owe to each other has really help to advance some of the conversations that we're talking about in healthcare generally. And I think that's a neat way for me also to go away and think about how do I articulate that sense of solidarity, and that maybe that running thread of how do we take advantage in the right kinds of ways of moments like this in time to then really help further that conversation and focus on what do we need in healthcare, how do we think about it from an organ and tissue perspective in particular. So yeah, I really like the NHS focus too. So thanks.
Fantastic. Robin, I think there was a question from Jen Chandler in the Zoom chat around engagement of First Nations and Indigenous populations. And I know that's something we as the entire LEADER program have talked about a lot. Would you like to comment on some of the issues around engaging specifically those populations?
Sure. So as of now, we haven't in the work that I've been doing as a part of LEADER. And to be honest, we would love to, but that actually comes down to the fact that I'm not an Indigenous health researcher, and it takes a whole lot of time to build trust with communities and so on to do that, to do research, but also it has to be an issue that they want research. They want to work with us to, and co-lead research on. And so we haven't, which I think is unfortunate when I look through all our data set that we have right now, and we don't have those perspectives. And so my plan is actually so I have a number of connections to I'm going to say various different health researchers and Indigenous health researchers through some organizations that I'm with. So I want to present this work to them, just what we've done so far, to see if there might be appetite to sort of co-lead some sort of similar research with our First Nations communities. But there has to be appetite, and they have to help, like they have to co-lead. Maybe the methods we use aren't appropriate, maybe, so it has to be done together. So
Yeah, and having been part of some of those conversations, I mean, it's certainly a priority, but it has to be done correctly, and we have to ensure that it is done with the respect and honoring the traditions and the procedures that have been established to avoid some of the historical abuses that have occurred.
Yeah.
And Stan, I think there are a few questions. One that I would submit to you is looking at the data that you presented, that since the 2017 reform of the law, there was no decrease and actually a bit of an increase in family refusals, yet no increase of the documented refusal required by the law. Is it correct then to assume that there are clinicians who are, say, and I don't want to, obviously don't name names, but is it a fair assumption that there could be some contravening of the law or not respecting the letter of this law, is that the clinicians have decided to accept oral refusal from the parents or from the families?
Well, yes, but it's not contributing to the law, because it's acceptable by the law. You can accept some oral. Well, I mean, I'm probably I wasn't clear enough when I said there was no signed document. It was no written document. There are two ways. Either the patient writes a document, says, I don't want to give my organs, and they give them to the family, and the family shows us this document. This only happens in 9% of the cases. The 91 remaining cases are the family saying he didn't want to give his organs, and we're going to sign this, and this is totally accepted by the law. So I was probably confusing, but no, there is no, in this aspect, there is no contributing to the law. Where it gets more tricky is when you see that there is a decrease of family refusal, but in the same time, there is an increase in patient refusal. I can talk for myself. I'm sure that within these figures, we can see that family understood better that they had to say that their beloved was opposed to organ donation. This ends the discussion, and we're gonna enter this as a patient's refusal. You understand what I say, or is it clear? Because when the interesting thing is, like, global refusal doesn't change. Now, this being said, there is a significant increase in organ donation, but it's slight, but it's still, it's 60 more donors per year, which makes 200 to 300 more transplantations. So, and it's significant statistically. Whether it's going to remain in time, whether it's an artifact, also I can tell. Yeah.
Fantastic. And then a couple questions as well. So one more to you, Stan, from an anonymous attendee, wondering if your guidelines for how to approach the families if they are accessible. S'ils sont accessibles en tout temps, et est-ce qu'ils sont systématisés? So are they systematic throughout France?
Well, thank you for the question. I don't know, this anonymous could be me, but I swear it's not me, because those guidelines actually were written by our research group for research and also, practical application in our centers. This was done in 2015. When the law change began to be in the air, the French agency in which I was closely collaborating with came to us and asked us, could we have your guidelines? And actually they published them, of course changed, but the spirit of those guidelines are actually published in the law. So they are completely systematized in terms of being in the law. Now, to be honest, so yes, they are accessible, but no one reads the law, actually, unfortunately. I mean, this decree, I don't have figures about that, but I can ask my colleagues. Most of them are not even aware that this decree was published with guidelines in it. And more disappointing is that in the context of our study, we not only published the guidelines, but we went over the 23 intensive care units and organ procurements to talk about those guidelines for an hour. And we can see that they were, our data show that they didn't change the way the meetings were done. So disappointing, but still work to be done. But that is the answer to the question. Yeah.
Nice. And I just quick time check, Jen. We have until 3:30. Is that correct? 3:30 Eastern.
Yes, indeed.
Okay, good. Then so we have one or two more questions. So there was one from Jed around, and I'll direct this to Christy first, although feel free to comment for the rest of the group, about solidarity and whether it should necessarily be a guiding principle or more of a goal. I don't know if you can see the rest of the question there.
Yeah, no, I think it's a really interesting question that Jed raises. And I think the way that I'm approaching solidarity at the moment, and I'll still be thinking about it, is that I don't think it's necessarily a goal or outcome. I think you could say we have greater or less solidarity at the end of a change or as a result of changes we're making, that people feel more included or connected in certain ways versus others. So in that sense, then, I think this is where I'm cautious about saying, or want to be clear about, solidarity is not a value in and of itself. It needs to be connected to some other values, because I don't know if solidarity, in the way that I'm understanding it, necessarily tells you whether what you're aiming at is ethically justified or appropriate, that you need to draw on some other values to say, we're in solidarity aiming towards this, and this is the good thing that we want to be aiming towards, whether it's organs or different things. Because I think you can certainly see strong solidarity among groups that would have their goals or their outcomes as being things that I would fundamentally disagree with, right? And so I think it's trying to work through that kind of space around solidarity that I'm coming from, but I think it's a really helpful question just for me to even be more clear about what I'm trying to articulate in this space. So thanks, Jed, for that.
Great. And then I'm going to kind of combine a few questions and maybe direct them to you, Robin. There were a few questions around education. And so, for example, whether incorporated it into the school curriculum or which source of education, be it the ODO versus the government. Are there any, from your interviews, were there any sense of where, and obviously we can't make a blanket statement for everyone, but any sense of which the source of information would be most effective?
So that's a great question, because I think it changes by community, and that's what I heard. So there are certain organizations, let's say, that are more credible or less credible with communities. So for example, leaders of the African Nova Scotian community were very we're very explicit that they don't have a lot of trust in the health authority here and confidence in the health authority. And so maybe that's not the most credible, they thought really having more of a different organization that's more transparent and autonomous and that sort of thing might be better. So I think it does vary by organization. Now, there was a lot of, so I do want to talk about education though, because Kimberly Dodds put in a question and I didn't answer it. I just said, oh, I'd love to talk about that. And I think then it looks like it's answered, but it was around education. So the question was there consideration to some tissue donations that do clearly save lives, like skin? And then perhaps we need clearer education on the impact of different donations and the ability for donors to choose. So I wanted to say there was. So, and this is where education is really important. So when I was doing data collection with leaders of and this is applicable mostly to faith-based communities, right? In terms of the Jewish and Islamic communities. And so there were so many questions around tissue donation, like so many that I'm not a critical care doc. I don't work for Legacy of Life. I couldn't answer. So I had to go back and get information and send them because they couldn't give me informed views without actually knowing the information, and particularly around tissue donation. So there were individuals who did understand that skin saved lives because they had sort of events happen within their community. There was a very tragic event in Nova Scotia a number of years ago that happened within the Islamic community, and so they knew that skin saved lives. It was around a house burning, and so but when we were able to get education, and Steve Bede helped with this, when we were able to give a lot of information and have a lot of conversations, communication with them, and sort of more like, I want to say, virtual sort of discussions and a bit of town hall like discussions, then they wanted to answer the questions again. And so when they had education, the tissue donation complexities, they became much more comfortable with, and they were very clear that, okay, if skin saves lives, we're okay. So saving a life is above our religious traditions and practices. Saving a life will always come first. These things are extremely important to us, like the sort of after death, the things that happen after death around religious rituals and so on. Extremely important, but saving a life will always come first. So they're very clear that, so again, that's the education, right? Which ones save lives and which ones don't. And I did feel many people felt, I know, much more comfortable after getting that education. And there were two issues really. I mean, wanted a really clear understanding of neurological determination of death, brain death, and around the tissue donation and what tissues save lives, what don't, what does a body look like after tissues are taken out, what, like all of those things. And so, I thought that question was really important, because once people had multiple conversations and education and materials were sent to them and so on, there was a much clearer understanding of that. And so out of that, around the ability for donors to choose very specifically, in this one example, there was certainly a huge conversation around, would it be acceptable under the legislation for us as a community to come up with sort of a statement, an agreed upon statement within our community and within our Council of Imams in this example, where we could say these things are acceptable, right? And these things are not based on our traditions and so on. And would that be something that Nova Scotia Health, for example, would put into policy? And is that allowed under the legislation? And so as I bring up all those things too, that sort of tells you why it's so important for communities to be engaged before the legislation is drafted or as it's being drafted, right?